Hello, everyone, and welcome to our pediatric NCLEX prep review. Today, we're going to be going over concepts of pediatric nursing, a little bit of newborn, a little bit of pediatrics. We'll go through normal assessment findings. We'll go through common pathophysiology. And yeah, just a little bit of a disclaimer, in no way am I associated with ATI or the NCLEX itself. I personally took my NCLEX in May of 2023, and these are the notes that I compiled along the way, and I would like to share with you guys. So without further ado, let's go ahead and get started. Okay. So first thing we're going to talk about is our normal vital signs. It's a good idea to have a general understanding of what is normal, specifically with kind of our neonates, honestly, up until our adolescence. Adolescents, you'll see their vital signs are most similar to adults. But right when a baby is born, usually their heart rate is going to be pretty high, between the 100s and the 200s. And their blood pressure is going to be a little bit low. Remember, they don't have as much circulating volume as adults. As the baby kind of gets a little bit older, you'll start to see those vital signs trend more towards what we know as normal vital signs for adults. Also, when babies are first born, they will have an increased respiratory rate, and eventually all of this does kind of even out. Keep in mind that in that immediate newborn period, there might be a little bit of kind of hypoxia, as these babies are learning to kind of breathe in the natural air as opposed to what they did when they were in mom's womb. But kind of we start to get concerned if we have a neonate that's maybe a couple days old and is kind of having these low oxygen saturations. With that, you might see a little bit of cyanosis, some grunting, some nasal flaring, things like that. Always remember that when we are in the immediate newborn period, we're avoiding rectal temperatures. We're going to try to prevent neck or any sort of infection. Okay. However, when we've kind of got more of our toddlers, preschools, and even our infants, then we can kind of use rectal temperatures. Okay. Alrighty. NCLEX likes to talk about abuse and neglect, and really how we differentiate the two and what we as nurses are supposed to do if we suspect any sort of abuse or neglect. So abuse, really some common assessment findings we might see is a child that has frequent emergency department visits. Mom might report an inconsistent story. Now, what do I mean by an inconsistent story? Well, we'll talk a bit more about development and milestones, but a 2-month-old baby shouldn't be rolling off the bed. They shouldn't be crawling yet. So if a mom says, oh, my 2-month-old was crawling and he hit his head on the counter, or he rolled over and fell off the bed, that's where these bruises are from. Well, that's an inconsistent story because the baby shouldn't be doing those things yet. So we kind of have to further evaluate. Sometimes if mom or the child appears withdrawn from each other. We have our shaken baby syndrome. You'll kind of see some issues with the baby's eyes, some inconsolability. Dip burns. Now, yes, a baby can kind of accidentally get burned, maybe was playing and had a little bit of a splash burn, and you'll see kind of burns like little dots. Okay, that we can kind of see is more like of an accident. But if we see what we call these dip burns, where let's say the bottom parts of the baby's legs have an even burn, almost looks like they're wearing red socks, to us that's not an accident, that was intentional. And then if baby has any reported STIs, that's something we want to evaluate. Neglect, on the other hand, is when parent fails to provide care for the child. Children and babies are dependent on the parents. Okay. You'll see poor hygiene in the baby, maybe a dull appearance. The school might say that the child has a lot of missed visits. Failure to thrive is something we look at, but we have to be careful with failure to thrive because there's many other factors that could cause the baby not to put on weight or the baby to be underweight. First thing we do is we as nurses want to observe how the baby eats. If we notice the baby's being kind of picky or isn't eating a lot and is maybe vomiting after feeds, Then we want to further evaluate because that isn't necessarily neglect. Maybe there's a pathophysiological reason that the baby is having a hard time eating, or maybe there's other factors like socioeconomic status or poverty that can cause some underweight children. Okay. Now we're going to talk about our milestones and really our growth and development of these little ones. So when we have an infant, these are the first 12 months of life. They are in that trust versus mistrust phase. The baby's whole persona basically relies on them being cared for, loved, and kept safe. If they get what they need, they're going to establish trust. If they lack the basic needs like food, water, toileting, baby's going to develop mistrust that can kind of progress throughout life. Okay. Some physical changes we see are baby's posterior fontanelles close at about 6 to 8 weeks, and then the anterior fontanelles don't close till about a year. Okay. We also look at body weight. Within the first 5 months, we really want that body weight to double the birth weight. And then at 1 year, we want the body weight to triple the birth weight. Okay. Psych wise, they're in the sensory motor stage. Okay. They kind of really learn by moving and grooving. Okay. They don't understand anything in the future, anything in the past. They understand things as what they are. They begin to start understanding the word no at 9 months, and they probably have about 3 to 5 words in their vocabulary at 12 months. Really, we focus on feeding and comfort. Couple other major milestones. I have them listed out for you guys. Big ones at month, they kind of start to have that hand grasp. At 4 to 6 months, they really start to roll side to side. They begin, to grasp. They might babble a little bit. At 8 months, they're kind of sitting upright. 9 months, they begin to start crawling and cruising. Now's the time to probably baby-proof the house. And then at 11 months, they can walk with assistance and they start to get that fine pincer grasp. And then really at 12 months, they're going to start walking. Okay. A big thing boards likes to focus on is what are age appropriate toys. This is going to be for education of mom, but also if you have a hospitalized pediatric patient, what are some appropriate things? So for our 0 to 12-month-olds, peekaboo, they don't have that object permanence yet. So when mom or dad or caregiver covers their face, baby are going to think that they're gone. So peekaboo is a very popular game with this group. Reading to them helps. They're not really able to turn the book because they haven't really got that fine pincer grasp till about 12. But really we want big toys. We don't want anything that could be a choking hazard. Okay. Vaccines are important. It's not important to memorize them, but just so that you are aware, lots of our vaccines happen within the first 6 months. Okay. Ideally, we want mom to breastfeed or formula feed exclusively for the first 4 months. Then we can start incorporating water at 4 months. But again, mom is going to continue to breastfeed as long as she can. We can start offering juice at 1 year. And then also within that 4 to 6 months, little Cheerios, soft foods. Okay. Big thing, we want the baby to be in a rear-facing car seat till they are 2 years old. And our focus is going to be on SIDS prevention, that sudden infant death syndrome. A big thing that we can do to help prevent that is going to be following our ABCs. When baby is sleeping, we want to, number one, make sure that they are alone. We do not want co-sleeping. We don't want them sleeping with their parents, their siblings, nothing like that. They need to be in a crib by themselves, so they are alone. We also want to make sure that they are laying on their back. Tummy time is okay, but tummy time should not be for sleeping. It should be while the baby's able to be observed. So we want them alone, we want them on their back, and we want them in a crib. We also don't want any blankets in there. We don't want the stuffed animals. We don't want toys in the crib, nothing in the crib that first year. Okay. Alrighty, up next we have our toddler age. This is ages 1 through 3 years old. They're kind of in that autonomy versus shame and doubt. They really want to be able to do things on their own. However, when they are told no or they're unable to do something, they feel very upset and they feel that it's their fault. They feel very guilty about it. So really in the toddler age, we want them to grow about 7.5 centimeters every year. And ideally at 2.5, we're going to quadruple the birth weight. Okay. These little ones are our magical thinkers and they learn through play. Okay. We want to give them choices and avoid a power struggle. Some milestones that our toddlers have at 18, they can start to walk up and down the stairs with help. They start running. Maybe now's the time to incorporate some outdoor activities like throwing a ball. They're able to pull and push. At 2 years, they can start kicking, drawing a little bit. They can speak in small sentences and really turn those book pages. And at 3, they can now speak in some simple sentences and pedal a tricycle. What are some age-appropriate toys, blocks, books, crayons, and parallel play? With their peers, toddlers won't necessarily interact with their friends, but you will have two toddlers kind of sitting next to each other, both in their own world, maybe playing with their own toys, but they enjoy being with others, but they're not necessarily playing with their friends. Okay. We can start incorporating some finger foods into their diet. We really do want to avoid sugar. Juice is fine, but sugar and milk can cause a lot of like dental caries, cavities. So we want to really kind of be careful about that. We can start incorporating about 6 to 8 ounces of juice. Now we have reached our preschool age. These little ones are 3 to 6, and they want to do everything themselves. They want to be as independent as possible. They want to try to do things on their own for the first time. Okay. Again, the issue with this is they see failure as a reflection on themselves. So that can kind of, when they are unsuccessful in their initiatives, they can have a little bit of guilt. Now we want we want the little ones to gain about 2 to 3 kilograms per year. And they will also start losing their teeth. Once they lose their first tooth, that is when you're going to want to start getting in those yearly or every 6-month dental visits. Okay. They are in the pre-operational phase. They are in a fantasy land. However, they can also understand past and future tenses. Okay. Where up until now, kids only understood the present. Now we can kind of see future and past, like, oh, we will go to the park tomorrow. Or, oh, mom brought by toys yesterday. They're able to understand that. Okay. A little thing about pediatric hospitalizations for preschool age is they think that illness is their fault. Okay. What do we as nurses want to do if we're explaining or demonstrating any sort of, procedures? We're going to first do it on the plush toy. We always perform an assessment on our pediatric patients, least invasive to most invasive. And I don't mean invasive like open heart surgery. I mean, what is going to kind of upset them a little bit. Usually our palpations, obviously our needle sticks, those are going to be the most uncomfortable. So first we're going to observe, we're going to assess them with our eyes, then we can listen to them with our stethoscope. We can also demonstrate, oh, I'm going to listen at you on the little plush bear. Then we can start kind of palpating them, okay? And then if we need to do any sort of lab draws, needle sticks, if we need to look in their ears with an otoscope, anything like that, we'll do last, okay? Why we do that last? If we upset the child and they're crying, it's going to throw off our assessments, okay? And then now they can kind of begin playing with others. Okay, now is the time that we might want to start incorporating playing outside with a ball. We can have a bike with training wheels, puzzles, pretend play. Okay. Now we have our school age. This is our industry versus inferiority. These kids are range from 6 to 12. And during this time period, they will begin puberty. Females usually start earlier at 8. The first sign of puberty in a female is going to be breast changes. Males begin puberty a little bit later at 11. And their first sign of puberty is testicle enlargement. Okay. They also begin to start developing some morals, and they are in that concrete operational phase. They crave rules, they crave structure, and they begin to understand more difficult concepts such as time, space, and quantity. Age-appropriate activity now is a great time to get them involved in school activities, little league sports, things like that. There's also a big portion of our school-age children is they can now begin to be involved in their care. What does this mean? If you have a pediatric patient with a chronic illness like diabetes, we want to know what can they do for themselves. Okay, so we have our 7s and our 12s. At age 7, think skills. They can perform skills. Okay, this includes an example of this would be giving themselves a shot of insulin. However, at 7, they can only do skills. They cannot manage, they cannot assess. So mom or dad or teacher, caregiver, whomever will need to check their sugar and say, okay, your sugar is this. I'm going to follow your sugar protocol. So if your sugar is X, you're going to get Y amount of insulin. At 7, they can't do that yet, but if you teach them how to give them a shot of insulin, that is a skill. At 7, they can perform skills. At 12 is now when we can manage their condition, okay? Not only do they know what to do with their condition, but they also know when they need to ask for help. So at 12, they can start to manage their condition. At 12, they can start checking their sugar and going from there, okay? And then now we've reached our young adult. These are our kind of our adolescents, 12 to 18. They are in the identity versus confusion phase. Again, these are our most formal operational thinkers. They are able to understand the hypothetical, theoretical thinking, abstract thinking, cause and effect, and two separate variables. Okay. They do develop a sense of self-identity. When they fail to identify that, they can have a little bit of a role confusion. We really focus on peer-to-peer interaction for our teens. That's going to be a priority for our young adults. When performing assessments on teens and our tweens, we want to keep them in civilian clothes. We want to keep them as comfortable as possible. We're going to start screening for scoliosis. Making sure that they're sleeping okay, sleeping through the night, encouraging nonviolent games and social activities. And as always, if it is safe for the child, have their friends visit, have them participate in school. If they're in the hospital, have them work on their homework. Okay, allow friends to visit. If it's safe, only time it wouldn't be safe if you had maybe teenager on reverse isolation, and they're really at risk for infection, then we can maybe set up some FaceTime, some video chats, phone calls, things like that. So how do we adapt nursing care for a child? For infants, they have stranger anxiety. We want to keep them in a routine and encourage family visits. It is normal for our children to have a little bit of regression in the hospital. It's a change of environment. It's a lot of stress. So maybe you'll have a toddler that wasn't wetting the bed. They become admitted. They've been in the hospital for a little bit, and they kind of revert back to bedwetting. Okay. Preschoolers, they're really scared of harm. They think that any sort of pain or bad health is them being punished. Okay. Really, we give choices when applicable, and we can we can explain procedures. Okay. School-age children really miss their friends in school, so we want to allow them to participate in whatever activities that they can. And then adolescents also very concerned that they are missing school, but now we've got a body image component, which is why we allow them to stay in their clothes. Okay. Also, when assessing for pain, until adolescence, we're going to use the FACES pain scale for pain assessments. Medication administration, this one is a big one. When you are administering eardrops to a child younger than 3, we pull the ear down and back, okay? Children will also require a spacer or mask when getting breathing treatments or any sort of inhaled medications. They might not be able to kind of keep the mask on themselves. You'll kind of see it's actually like a mask that covers their entire face, or some sort of spacer for albuterol. This helps ensure that they're getting all the medication. And then when giving liquid medication to an to an infant, we have them kind of suck on it through a bottle with a nipple attachment. Death and dying does occur. It occurs to kind of everybody. So we really need to understand what is the child understanding and what do they believe is going on. Our infants don't really understand what's going on. Kind of as we get a little bit older, like with our toddlers, they begin to have an idea. Toddlers, however, don't understand the concepts. All that they understand is that there's been a change. If toddler is hospitalized with, maybe a chronic condition that has a very, very poor prognosis, or like a late stage cancer, they're not really going to understand death per se, but they will understand that there's a change in their environment, and that is going to stress them out. Preschoolers focus on ego. They view death as a form of punishment, as if they did something wrong. They also view death as temporary. Okay. When we get to our school-age children, they begin to understand that death is permanent. Okay. And then our adolescents and young adults, they're really going to crave support from their peers. They're going to be most distressed by the physical changes that occur in their body and have a little bit of guilt and shame as a result of that. We already talked a lot about age-appropriate toys. Really want to hit home on infants, making sure that we're not using anything small that they could choke on. We want soft and large toys. Toddlers don't really have that great of finger dexterity, so push and pull toys are best. They can finger paint. Finger painting and turning a book is not recommended. They don't really have that pincer grasp. But scribbling with a crayon, they can, because they can kind of grip that whole crayon in their hand and kind of scribble, scrabble. And again, parallel play. Our preschoolers, we really want to hone in on working on their fine motor skills. They now kind of have that pincer grasp. So reading a picture book, turning, finger painting, all of those will help. School-age children, now is when we want to get them involved in some organized sports and little leagues. And adolescents, we focus on peers and safety. Okay. Now we are going to talk about our congenital anomalies. A lot of pediatric nursing focuses on the care of a pediatric patient and how we are going to take any sort of pathophysiological process, how we're going to not only care for that process and that disease, but how we are going to care for a pediatric patient in general. So all of it is going to come together. We're going to learn how to care for the disease. We're going to learn about the disease processes, but then how do we alter our care to make sure that it's age appropriate for these little ones? Okay. Pulmonary congestion is very common in birth. These little ones often present with some retraction, nasal flaring, grunting, or wheezing. None of those are normal findings in a child. If they have any of these, we want to think that they're having a little bit of respiratory difficulty. This is usually treated with some nebulizer or breathing treatments. Again, using a spacer or a mask is key. Clubfoot is a very common congenital anomaly. One of their feet is very, very small and the toes do curl inward. How this is treated is a weekly cast. They get a new cast every week to kind of help straighten out that foot. However, these patients are at increased risk for hip dysplasia, so we're going to want to assess and monitor for that. Cerebral palsy is common. They have alterations in both muscular and motor control. Our airway is going to be our priority concern, so making sure the head of the bed is elevated and that you have suction at bedside, very, very important in kind of the early development, especially with our newborns. Every newborn in general lacks a little bit of head control, but especially with cerebral palsy, that's going to be exacerbated. Baclofen medication does help. Cleft lip, cleft palate is common. We really want to focus on safe feeding because they have obviously this cleft in their lips, so they have a little bit of a harder time performing and acquiring a good seal. So things that we can do is, give mom a special bottle that has a special nipple, and as baby is feeding, we're going to want to help them with that seal by pinching their little cheeks closed. Feeding upright is super, super important, and we're going to want to take things a little bit slower. We're going to want to burp them after every ounce. Treatment for this is going to be surgical repair. After it has been surgically repaired, we want to avoid, touching the area. Up next, we have trisomy 21. You will have the hallmark palmar creases and kind of enlarged anterior fontanelles. Big thing with trisomy 21 is that these little ones are at an increased risk for leukemia, some other cancers. Okay, and we'll talk a little bit more about that in our pediatric oncology portion. Up next, we have our tracheoesophageal fistula. Essentially, this creates excess fluid to build up in the mouth, which poses a choking and aspiration risk to the little one. Most often, they have difficulties during feeds. They'll start to begin to have difficulties with feeding, choking, turning a little bit blue. Again, choking is our priority. Okay. DDH is common. This is developmental dysplasia of the hip. Little ones will have a positive Trendelenburg sign, kind of when we hold them up, and you'll see little folds in their legs. This is treated with a hip spica cast with traction, okay? And then after we've kind of done the spica cast and traction, as we're kind of helping in recovery, they'll require a Pavlik harness. It's very important with the Pavlik harness that we keep this on at all times, and we're not going to try to alter the harness straps. When we are swaddling a baby with DDH, we really want to make sure that we're pulling the knees up and tucked into the abdomen, so we're kind of flexing the hips up, and we're going to swaddle them that way. Okay. Kawasaki disease occurs very commonly in newborns. You'll start to see a rash that begins to peel. While the rash is not necessarily our priority concern with Kawasaki disease, it can actually cause a coronary artery aneurysm. So it's very important we give IV immunoglobulins, and we also give some aspirin. We're also going to want to make sure we get an echo, as this disease can damage the heart. Okay. All right. Up next, we have oncology. So first up, we have our ALL. Again, we already discussed risk factors include trisomy 21. You'll start to see the little one have a lot of fevers and bruising. They will require a bone marrow transplant, so it's important we screen parents as possible donors. Next, we have our Hodgkin's lymphoma. You'll start to see some swollen lymph nodes, frequent cough, and some night sweats. Tumors specifically are brain tumors in pediatrics. Kind of where we have difficulties with pediatric oncology patients is the younger the child, we're not always able to get an answer when we ask them what's wrong. So you'll start to see maybe little one complaining of a headache, but more often than not, parents will start to notice behavioral changes. Neuroblastoma, this type of cancer does metastasize very quickly. They will present with an abdominal mass. Okay, so that's why it's important during those visits that we're doing kind of our palpations. Osteosarcoma causes some bone spurs, which leads to really weak, brittle bones. Mom might notice her child was walking normally and is now limping. Encourage like flexion to help relieve the pain. Wilms tumor is a tumor of the kidney. We want to avoid palpating the abdomen for pediatrics with a Wilms tumor. Aplastic anemia, these little ones have low blood cell counts. We want to check the bone marrow. Again, they might require any sort of replacement. Really what's missing, are they kind of lacking white blood cells, or lacking plasma? What's going on? So checking the bone marrow helps. And then finally, we have sickle cell anemia. With sickle cell anemia, these little ones have lots of pain. So we want to really encourage a PCA pump for pain. Again, how are we assessing pain? We're assessing for faces. Okay. Ice and Demerol do not help for sickle cell anemia exacerbation, so keep that in mind. Heat, on the other hand, will. And we'll go in more detail about sickle cell anemia in just a little bit. But in general, our nursing interventions for pediatric oncology patients, we want to focus on keeping them infection-free. Reverse isolation is very, very important. But we also want to try to keep a normal routine. And if we're able to, encourage school. Okay. Up next, we have our congenital heart defects. We group them by cyanotic versus acyanotic. So what happens with an acyanotic congenital heart defect? We are essentially mixing oxygenated blood with deoxygenated blood. So regardless, the blood that's going to come out to the body is going to be oxygenated. Why? I'm just going to scroll down for a little bit. With our acyanotic disease, remember, after blood has went through the lungs, it's become oxygenated, it ends up in the left side of the heart. There's an issue where blood from the left side of the heart flows back into the right side of the heart. So essentially, oxygenated blood, which is good, is mixing with deoxygenated blood. Now, this can lead to a little bit of poor perfusion because we're not getting as much blood out. However, it's important to know that the blood that goes out to the body is still going to be oxygenated. It just might take a little bit longer to get there. Where when we have our cyanotic heart defects, we've got a right to left shunt, meaning deoxygenated blood is getting shunted into the left side of the heart, and therefore that deoxygenated blood is now in the left side of the heart. And what's the left side of the heart going to do? Pump it out to the body. So essentially, we're pumping out blood to the body that has not been oxygenated yet because it hasn't gotten to the lungs yet because of that right to left shunt. Therefore, we'll see some cyanotic findings. Okay. So what are these congenital heart defects? The first we have is a ventricular septal defect, again, left to right shunt. Lots of these, you'll have some cyanosis with crying and a left heart murmur. Okay. With our atrial septal defect, again, another left to right shunt. But with atrial septal defect, you'll start to see some cardiac dysrhythmias, a little bit of a murmur, and some dyspnea on exertion. And a lot of people ask, well, if it's acyanotic, why are they having some cyanosis? Why are they having shortness of breath? Well, it's just because when we have a shunt, we're not getting the quantity of blood out to the body as we should. The only difference between cyanotic and acyanotic heart defects is that we're looking at, does the blood that is going out to the body, regardless of quantity, is it oxygenated or not? Okay. With our patent ductus arteriosus, we have left to right shunt again. Hallmark finding for this is going to be a washing machine murmur. A lot of difficulty during feeds. Why are there so many difficulties during feeds? Well, babies' kind of lips are closed. They're trying to breathe through their nose. And so when feeding, these babies already have a little bit of a harder time kind of oxygenating themselves. But when we start to throw in a heart defect and we're kind of not getting as much O2 out to the body, as much oxygenated blood out to the body, we're going to see, those respiratory oxygenation assessment findings, like the inconsolability, dyspnea, and whatnot. We're going to see that kind of expanded during feeds. Okay. Then we have our coarctation of the aorta. Big thing with COA is differences in blood pressure. So in their upper extremities, they're going to be hypertensive. And then in lower, they're going to be hypotensive. Okay. And then finally, we have tetralogy of Fallot. This is a cyanotic congenital heart defect. It's combined of four things. We have an overriding aorta, a VSD, right ventricular hypertrophy, and pulmonary stenosis. These little ones will have TET spells where their lips might turn a little bit blue. They'll have some retractions, difficulty breathing. And to relieve this, they will put themselves in the knee chest position, or they will tripod. Again, we'll also have some cyanosis during feeds. A big issue with TOF is that they're going to have a risk of heart failure, cardiomegaly. So treatment is going to be surgical, and they really want to do that within the first year of life. Okay. Symptoms of our acyanotic heart defects. These are left to right shunts. As we've discussed, they're going to have some grunting during feeds, some heart murmurs, difficulties gaining weight. Why? Because of the issues with feeding. Okay. And then finally, our cyanotic heart defects, which is our right to left shunts. You're going to start to see some cyanosis, clubbing of the fingers. When we've done a surgical intervention, we're going to want to make sure that we are assessing for symptoms of heart failure after surgery. Okay. Now we get to talk about pediatric GI and GU conditions. A lot of our pathophysiology for peds is focused on GI and GU. First, we have intussusception. Essentially, there is telescoping of the intestine that causes lots of abdominal pain, and the pain is going to cause these babies to draw their knees up. They also have some jelly-like stools, okay? While they're having this exacerbation, we want to keep them NPO and give IV fluids. Treatment can be an air enema. Essentially, we're going to want to pull out and widen the intestines. Okay. Our goal though is to have a normal poop. If you notice baby has a normal poop, we're good. We're not going to want to do surgery, nothing like that. Look at the baby's poops. However, if baby's not pooping, we think that there might be some sort of perforation or ischemia. GI infections are common. We're going to treat as such with antibiotics. But with our little ones, we want to focus on oral fluids. Okay. Next, we have pyloric stenosis. This causes projectile vomiting after feeds. You'll also see like an an olive-shaped mass in the upper abdomen. Because of this projectile vomiting after feeds, we want to assess the little one for dehydration. Okay. Next, we have hyperbilirubinemia. Again, our big issue with this is assessing for dehydration. We talked all about this in our newborn lecture, and we'll talk a little bit more in a little bit about phototherapy. But that's really how we're going to treat the hyperbilirubinemia. Up next, we have Hirschsprung's disease. You'll start to notice that after the first 24, 48 hours, baby has not passed meconium, or the baby's having some constipation. This is caused by a lack of ganglion cells, and the baby will have a ribbon-like stools. How we kind of work with Hirschsprung's disease is incorporating a low fiber diet. Then we have acute appendicitis. They will have the right lower quadrant pain and a positive Romberg sign. Okay. Again, our issue with acute appendicitis is if the appendix bursts. So if the baby starts to have no pain, they're not crying anymore, they're not inconsolable anymore, and you start to notice their temperature is increasing and their stomach has become rigid and they're guarding, we believe that there is a rupture and that we're going to need surgery. If it does rupture, we're going to need to make sure that we do some NG suction, okay? During this phase, we want to keep them NPO, give them IV fluids and antibiotics. Up next, we have acute glomerulonephritis. This often causes from some sort of infection, but what happens is our infection causes our kidneys to kind of have a little bit of an issue with filtering and functioning. So a little one is going to present with some edema, decreased output, hypertension, and tea-colored urine. If we see these findings in a pediatric patient that presents to the ER, we want to ask mom, was the child recently sick? Were they around anyone that was sick? Because this will come as an effect of an acute infection, usually our strep pneumo or any sort of viral infection. We're going to want to do frequent cardiovascular and respiratory assessments to assess for complications. And we're going to want to get the little one started on antibiotics. And we're going to want to restrict sodium and restrict water. Up next, we have minimal change nephrotic syndrome. This is treated with immunosuppressants and a low sodium diet. Okay, you'll start to see edema and hypercholesteremia in these little ones. And they're essentially going to have a lot of albumin and protein loss in the urine. Neck is a big issue in our peds. We talked a lot about this in our newborn lecture. Kind of measuring abdominal girth, my apologies, is going to be the most important thing for these little ones. We also look for some sausage-shaped intestine. The issue is if this ruptures, baby is going to go septic very, very quickly. Rotavirus is common with pediatrics. Our priority is just going to be proper hand washing. For kids, we don't recommend the brat diet, banana, rice, applesauce, toast. Instead, we really just focus on rehydrating. And then finally, we have phenylketonuria. Again, this is genetic disorder that impairs the breakdown of protein foods. Okay, so what are we going to do? We're just going to follow a low meat and dairy diet. Up next, we have our UTIs. You'll start to see incontinence in children that were not incontinent before. It's very important we get a clean catch sample after their first void. The issue with our UTIs is that it can progress to acute pyelonephritis. They will have kind of the CVA pain, and a lot of tenderness kind of in the upper backs. Really, again, our issue with little ones is they can go septic very, very fast. Up next, we have iron deficiency anemia. Increased calcium intake can lead to iron deficiency anemia. That's why we stress kind of formula feeds or breast feeding, and we're not really introducing milk to little ones. Not only does it cause, dental erosion, but it can cause some anemia. Okay. Type 1 diabetes can present at any time. Our goal is to keep our sugars stable. Hypoglycemia is going to be our priority. You'll start to see the child being irritated and lethargic. All right, now we're going to talk about our pediatric respiratory conditions. First up is our tonsillitis. That's our swollen kind of tonsils, and very painful. They'll have a little bit of a hard time hearing because everything is kind of swollen here. It's going to impair the ears and some difficulty breathing. It's important to know our nursing interventions for a tonsillectomy. Kids with chronic tonsillitis will just have their tonsils taken out. So as always, we're going to watch airway, breathing, and circulation, keeping that head of bed elevated. After a tonsillectomy, we want to make sure that we are avoiding straws. We do not want any sort of straws until they are fully healed. And a soft diet is important. If you start noticing the child is frequently swallowing, this can indicate that there's some sort of bleed. So we're going to want to keep them NPO and consult surgery again. Bronchitis is that inflammation of the bronchioles. A lot of what we're going to do for that is just nebulizer treatments. Again, making sure we have that spacer. Cough suppressants are not recommended for pediatrics. Anaphylaxis is an allergic reaction, a total body response to an allergen. This is always going to be a priority finding. Little one's going to have shortness of breath and wheezing. What can we do? EpiPen. We're also going to teach parents or caregivers how to use the EpiPen. Remember, with an EpiPen, you can only use it once. It's for one-time use. Once you use it, you've got to dispose of it in sharps. And an EpiPen can be administered over clothing. Up next, we have bronchiolitis. Bronchiolitis is caused by RSV. The issue with this is that we might require some oxygen or ventilation, depending on how bad it is. Okay. Up next, we have a respiratory distress syndrome. You'll start to see a respiratory rate over 60. In children, children or babies, we don't want a respiratory rate over 60. You'll start to see hypoxia. These little ones might require CPAP. RDS is very common in premature birth. Their lungs haven't fully developed. So if you have a preemie baby, they're probably going to give surfactant and some caffeine to help stimulate kind of lung development. Okay, if the baby's respiratory rate is elevated over 60, we want to keep them NPO. We're not going to want to feed them. Remember, feeding requires oxygen consumption. Because they are feeding, they're going to go already a little bit hypoxic during feeds. So if they're already having these issues, we're not going to want to feed them. Okay. Strep throat is common in pediatrics. However, we start to get concerned for lockjaw, and we also get concerned for post-strep glomerulonephritis. We talked about it a few slides ago, but again, we've got gross hematuria, edema, and hypertension. How is this treated? We give them penicillin G. And then after 24 hours, they're no longer contagious. Now we're going to talk about croup. Essentially, croup is just like a classification of all of these disorders. Really, it's classified by that kind of inflammation in the airways and just that croupy cough. Okay. First, we've got acute epiglottitis. Okay, these little ones will have a frog-like voice with stridor and some drooling. Big thing for nursing is not to examine the throat. It can cause kind of a laryngospasm and the throat can close up. We're going to want to treat with steroids. If it's caused by Hib, we're going to give antibiotics. Okay. When we see drooling in a child, this requires immediate intubation. It's a priority. It means that they're no longer protecting their airway. Okay. Up next, we have acute laryngotracheal bronchitis. This is caused by the parainfluenza virus. These little ones have a barking cough that's worse at night. This runs its course for a couple weeks. Really, we treat it supportively with like a cool mist. Again, they can get some nebulizing treatments, etc. Up next, we have acute spasmodic laryngitis, usually due to allergies. Again, supportive measures, cool mist, cool vapors. And finally, we have RSV. RSV is also treated supportively. However, if the child's been having symptoms for longer than 3 to 6 days, we're going to want to bring them in. Okay. Up next, we have some pediatric neurological and neurosensory conditions. First one is going to be our meningitis. We assess their fontanelles. Are their fontanelles bulging? We're also going to want to get a spinal tap to assess the CSF to see if we've got bacterial or viral meningitis. You'll start to see the baby have some nuchal rigidity. Very important, we elevate the head of the bed, we decrease stimuli, want to decrease further inflammation to the brain, okay? And we start them on antibiotics as soon as possible. Remember, what we do to assess for adults is we look at the Babinski reflex. Remember, in our 1 to 2-year-olds, it's normal for them to have a Babinski reflex, or when you stroke the foot, their toes fan out. In our 1 to 2-year-olds, that doesn't always indicate bacterial meningitis, so that's just something to keep in mind. Then we have Reyes syndrome. This can either be caused by viral infection or aspirin use. We never give aspirin to anybody less than 16 years old. This can cause brain swelling and liver damage. You'll start to see alterations in level of consciousness and a fever, and you'll start to see increased ammonia and liver enzymes. We treat with vitamin K, and again, keeping that head of bed at 30 degrees. Up next, we have our neonatal seizures. You might not see the tonic-clonic seizures in our neonates. Their seizure signs might be a little bit more subtle, like repeated blinking. A big thing is assessing for temperatures. Elevated temperatures can cause neonatal seizures. Next, we have increased intracranial pressure with the babies. We'll start to see their sun-setting eyes. We want to assess vital signs for Cushing's triad. They're going to have irregular respirations, a widened pulse pressure, and some bradycardia. Next, we have hydrocephalus. Essentially, we've got fluid that's not draining from the brain, so we're going to need to place a shunt to help drain, to thus reduce inflammation. If you've had a baby that's gotten a shunt, we want to make sure we're not lying them on the side of their shunt. Okay. Again, watching for Cushing's triad and lethargy. Why are we doing that? We're watching for increased ICP. That can indicate that the surgery was either unsuccessful or there's an issue with the surgery, and there's an issue with the shunt itself. And then finally, substance abuse. Really, the goal is to decrease stimulation for these little ones, and we do want to involve mom in the care. Okay. Up next, we have a little bit of our pediatric eye and ear disorders. Up first, we have a neuroblastoma, and while this isn't an disorder of the eye or the ear, we kind of can diagnose, or we can begin to maybe suspect the pediatric patient does have neuroblastoma based on eye findings, if that makes sense. So essentially, when you give the child the color chart of that little book with the numbers, and you're supposed to be able to read, it's all dots, what number is in the book, these patients will have no red reflex, meaning they can't really differentiate reds. Okay. This is a cancer of the adrenal glands. Up next, we have myopia. This is nearsightedness, meaning child can't see long distance. We assess with a Snellen chart. Up next, we have strabismus. These little ones, their eyes won't move in the same direction at the same time. They have poor muscle control. So they won't be, both of their eyes won't be looking in the same direction. What do? We're going to try to train the bad eye, essentially. So how do we do that? We cover up the good eye and we just train the bad eye. Hearing loss, again, our issue with pediatrics is we can't always ask them what's wrong. Sometimes they're unable to tell us or they simply don't know what's wrong. So we have to kind of dig a little bit deeper. So if you start to see child is appearing a little bit withdrawn, they speak in a monotone voice, or maybe it's monotone but very loud, there might be a little bit of hearing loss. And then up next, we have pediatric immune and infectious disease. This slide is some common infections that can occur in our little ones. We focus on like isolation, treatment, things like that. Chickenpox will require airborne precautions. They are contagious a day before the symptoms start until the crusts form. We treat with acyclovir and some topical creams. Diphtheria will also require airborne precautions. With Fifth's disease, we have the hallmark slap cheek rash. This is caused by parvovirus spread by droplets. However, when the child is symptomatic, they cannot spread Fifth's disease. They are contagious before the rash appears. With our EBV, Epstein-Barr virus, our priority is going to be assessing the airway. Like we talked about earlier, drooling requires immediate intubation. Pertussis is our whooping cough. It can last about 4 to 6 weeks. We focus on supportive treatments such as fluids and humidified oxygen. We place these peds on droplet precautions. It is contagious for up to 21 days or once they have finished 5 days of antibiotics. Rosceola, these patients have a hallmark trunk rash and some elevated temperatures. We really want to assess for balding fontanelles. Any sort of increased intracranial pressure puts them at risk for seizures. Fevers also puts them at risk for seizures. So we want to make sure these patients are on seizure precautions. Scarlet fever, in addition to the fever, they will have a strawberry tongue and a full body rash that's going to be essentially everywhere but the face. This is caused by strep pyogens, but they are no longer contagious about a day after antibiotic treatment. Up next, we have mumps. This requires droplet and contact precautions. Really, they've got a lot of swelling of the parotid gland, so watch that airway. Measles requires the post-exposure prophylaxis vaccines within 72 hours of exposure. Okay, they can have a little bit of a rash. You want to avoid calamine lotion. Vitamin A helps. And then finally, we've got rubella. They are contagious basically 7 days before symptom onset to 5 days after the rash. Live vaccines include the MMR, the rotavirus, varicella zoster, polio, and yellow fever. With our pediatric patients, we want to really focus on hand washing. We do need to give vaccine. A cool compress afterwards can help. We're going to want to use, I want to give the IM injection in the glute for peds. Alrighty. Up next, we have otitis media. This is an ear infection. Upon otoscope, you'll see a bulging, painful red eardrum. Really, we want to focus on antibiotics. How do we give these antibiotics? We can give them in the ear if we're giving ear drops. Remember, for children under 3, we pull the ear down and back. For children over 3, we pull the ear up and back. If a little one has frequent ear infections, this might be due to a structural issue where the ear canal is a little bit smaller, so they might require tubes. If they require tubes placed in that ear canal, we want to keep the water out of them. Infectious mononucleosis is our kissing disease. It is caused by the Epstein-Barr virus. Treatment is supportive with breast and fluids. We want to assess for spleen damage. Next, we have impetigo. Essentially, they have some erythema and honey crusts along the face. What do we do for this? We wash and remove the crusts, and we treat with penicillin. Pinworms, these patients have the hallmark anal itching. What do we want to do is we want to prevent itching. Hand washing is key because this is spread by essentially when you touch the site, that is how you can spread it. The medications for pinworms can actually turn the stools red, so that's just something to be aware of. Ringworm has that hallmark circular rash, and we treat with antifungals to help with kind of some discomfort. Stomach discomfort we can give with fatty foods. For scabies, these patients have an itchy pin-like rash that is treated with permethrin cream. For a little one with scabies, if they've got kind of those items that they can't seem to throw away, like their favorite toy, we can wash the belongings with soap and hot water. Head lice, very common kind of in like our toddler school age group. This is treated by essentially combing through the hair with a pyrethin shampoo. Treatment can take about 7 to 10 days. Again, if you've got those items that just can't be thrown away, we're going to wash those clothes and toys in hot water and seal in a Ziploc bag for 7 to 10 days. Up next, we have osteomyelitis, infection of the bone. They will have hot pain on the bones. This is treated with IV antibiotics. It's going to be long-term, so the little one's probably going to be sent home with PICC line. Okay. And then finally, we've got botulism. This is an infection from the botulinum toxin. This is why we never give children under 12 months honey. Okay. This can come from raw honey. Symptoms will include lack of head control, decreased reflexes, and respiratory failure. Eventually, they'll have some ascending paralysis too. All right, my beautiful people. And finally, we've got our pediatric chronic conditions. So we've talked about the acute, we've talked about different body systems. Now we're going to talk about our pediatric chronic condition. So cystic fibrosis is a genetic disorder, okay, causes some issue with mucus production. These little ones also have salty tasting skin. This will require frequent chest physiotherapy, nebulizer treatments, fluids, increasing calories and proteins, giving some pancreatic enzymes. Really, it's important we focus on infection prevention. We want to avoid any sort of respiratory infection. Next, we have scoliosis, common with our adolescents. This is why every year they do a scoliosis screening at the annual physical. Really, treatment is dependent on how severe the curve is. For a curve that's 25 to 45 degrees, we wear a brace for 23 hours. They can take it off to shower, but they're going to need to wear it for about 23 hours a day. If the degree of curvature is greater than 45, it's going to require surgery. After surgery, it's important that we log roll these patients. Hypothyroidism, essentially they have lack of our T3, T4, basically our energy. So what are we going to see? We're going to see drowsiness, hoarse cry, and dry skin for these little ones. Up next, we have sickle cell anemia. This puts anybody at big risk for stroke, seizure, and pulmonary embolism because our red blood cells are sickled. Remember our treatment, we hop to it, we hydrate, we provide oxygen, and then we provide pain medications. Warm compresses help. Remember, we want to avoid ice. We also avoid meperidine in pediatrics. Our concern with sickle cell anemia is that these patients can develop chest syndrome, which essentially is an ammonia-like infection in the lungs. Up next, we have hemophilia. Basically, we're missing a factor that helps our blood clot. So we treat based on the missing factor. Someone with type A hemophilia is missing factor VII. Type B hemophilia is factor IX. What do we do for hemophilia? We want to try to prevent any sort of injury because, again, they have issues with clotting, which leads to increased bruising, poor healing, etc. So we use our RICE method for injuries: rest, ice, compression, and elevate. Want to avoid aspirin. Remember, we're avoiding that Reye syndrome. No aspirin. For pain and whatnot, we can give acetaminophen. Issue with hemophilia is that they are at increased risk for developing arthrosis. Up next, we have osteogenesis imperfecta. We'll see the hallmark symptoms of a blue sclera, brittle teeth, and essentially brittle bones that are very, very prone to fractures. When caring for these children, make sure that when we're holding the babies, we're holding them by an area that is larger. We're not pulling the child up by their arms. We're going to try to grab them by their trunk, hands under the arms, why they are at risk for fractures. And then we have our Duchenne muscular dystrophy. This is an X-linked genetic disorder, meaning it's going to be more prevalent in males because females are XX. So you kind of have 50-50, whereas males are XY. So if they get the X chromosome that has the genetic disorder, that's all that they're going to get. There's nothing to kind of balance it out. While females can be carriers, males are going to present with the DMD. Okay. They will have the hallmark Gower sign. They will push with their hands on their legs to stand, and they will tiptoe as they walk. Next, we have atopic dermatitis. This is just eczema. We treat with antihistamines. Emollient creams can help soothe the flare-ups. And then finally, we have acne. It is a perfectly normal finding in teenagers and young adults. We want to encourage healthy diet, proper hygiene, good sleep. And then we're going to provide education to use a non-comedogenic mild cleanser. We're going to teach them not to pick at or scrub the acne. So that is all I have for you guys. Thank you for coming to this crash course. As you can see, pediatrics does have quite a few patho points to it. But remember, with pediatrics, not only are we treating the disease process, but we're also treating a child. So we do need to adapt nursing care. So be prepared to know maybe some of our common pediatric conditions and how we're, again, not only going to care for the condition, but care for the pediatric patient. So thank you so much. And as always, if anybody needs anything, please let me know.